Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm speaking to the chair of the Royal College of GPs, Professor Kamila Hawthorne, ahead of the RCGP's annual conference in Liverpool, which starts on Thursday this week. GP Online is once again the media partner for the annual conference, and this is the first of 3 daily episodes that we'll be producing from the event this week. Coming up today, I'm talking to Kamila about the RCGP Council's recent vote to oppose a role for physician associates in general practice, health inequalities and why funding for general practice needs to change to better reflect deprivation, and the current challenges new GPs are facing finding work. Kamila also explains her views on whether the new Labour government will make a positive difference to general practice, and what the college wants to see happen to improve GP retention and boost the GP workforce. You can catch up with all the latest news from the RCGP annual conference in Liverpool this week on our website at GPonline.com/RCGP. These special episodes of Talking General Practice at the RCGP annual conference have been supported by CoppaFeel. CoppaFeel are the UK's only youth-focused breast cancer awareness charity, and they're on a mission to get every 18 to 24-year-old checking their chest. CoppaFeel educates people on the signs of breast cancer and encourages them to check their chests monthly, so that if they notice something unusual for them, they are empowered to contact their GP and advocate for themselves. CoppaFeel also provides resources and e-learning to healthcare professionals to support them in encouraging breast awareness with their patients. For more information, visit coppafeel.org. I'm delighted to be joined on the podcast now by Chair of the Royal College of GPs, Professor Kamila Hawthorne. Kamila's been chair of the college since 2022 and has been a GP for 32 years, mostly working in South Wales. Her research and clinical working interests have been in health inequalities and access to health services. Thank you so much for coming on the podcast again, Kamila.
It's a real pleasure, Emma. Thanks for having me.
So firstly, I wanted to talk to you about physician associates. I mean, the whole debate about the use of physician associates in the NHS has been a really important issue over the past year. The college has just made a very significant intervention on this and changed its position and now says it opposes the role of PAs in general practice. Why has the RCGP's position changed?
So this is the position of the RCGP's council. And of course, as chair of council, it's my role to make sure that council's thinking is reflected in what the college says and does. So 6 months ago, council was still in the position of saying that it was an enabling role in general practice for physician associates. But in the meantime, we've held a pretty big consultation of our members in which it's become very clear that a significant number are saying that there isn't a role for PAs in general practice. As our council members prepared for council on the 20th of September and our conversations with our faculty boards, again, they brought to council the same opinion that there really wasn't a role for PAs in general practice. And so we felt that we needed to put that to a vote and voted pretty heavily that there really isn't a role for PAs in general practice. And this is why we've changed our position.
So what does all this mean for PAs currently working in general practice and the practices who are employing them? I know the college is still working on new guidance related to the PA role in general practice. Why is that guidance still important and what exactly will it be covering?
So there must be at least 2,000 PAs working in general practice across the 4 nations of the UK currently, and they must be feeling pretty uncertain about what they should and shouldn't be doing and what their future holds for them. We feel as a college that it's important to both support and supervise them so that they can be safe for patients, safe for themselves and safe for their employers. And so this guidance, which we'll be coming out in the next couple of weeks, covers the induction and preceptorship of newly trained PAs, supervision of PAs and their scope of role. I think would be very useful.
You've obviously had a real interest in health inequalities throughout your career. I know it was one of the key issues you wanted the college to look at during your time as chair. Can you talk a bit about some of the work the college has been involved in recently on health inequalities?
So we look at our health inequality strategic priority in 3 levels, if you like. There's the level of what can we as a college help grassroots GPs with in addressing the health inequalities gap in their day-to-day work, in their practices. The next level up is what could be done at ICB or cluster level, if you're outside of England, to address health inequalities. And then the final level, if you like, is what can we be doing centrally in our influencing work, working with other partners in the field to influence government in the way in which it looks on health and social care, but also social policy, because we all know that it's the social inequalities that underlie an awful lot of the health inequalities that we see. That level, for example, we've been developing relationships with the Trussell Trust, the Joseph Rowntree Foundation, the Health Inequalities Alliance that's led by the Royal College of Physicians of London, and a number of patient organisations as well, to lobby government. And of course, it's been really important this year with a general election. We've been very keen to get the party manifestos to include commitments to reducing both social and health inequalities. So, for example, we were delighted to see that the Labour Party in its manifesto was talking about aiming to halve the health inequalities gap between affluent and disadvantaged areas during its term of office. That kind of thing we see as a real win on everybody's part, including our own. For us at that level, we're also lobbying for a redistribution of funding and actually probably new funding into disadvantaged areas for practices in those areas where we know they see more patients. There are more patients per full-time equivalent GP, about 14% more, but they get less funding because it's much more difficult to achieve targets and do the prevention work that also attracts funding. We need a very careful look at the way in which the funding is distributed in all pockets of funding, not just the Cahill formula. And there are some really interesting examples of innovative practice amongst some of the ICBs in England, where they're looking at how they distribute their health inequalities budgets to those practices and are starting to see some differences and improvements as a result of that. So part of our role is to find these areas of innovation and publicize them and share good practice. At the grassroots level, coming back full circle, we've also got a fantastic health inequalities hub on our website with lots and lots of great resources for people who are either just starting out in health inequalities or have been doing it for a while and are looking for new challenges and new ways of working, as well as linking up with other like-minded GPs so that they can work together. And again, we very much support organisations like the Deep End practices across the UK.
Just coming back to that point on funding, the college, doesn't normally get involved in conversations around things like the contract. You have said that all funding streams need to be overhauled. Do you think the Cahill formula needs to have a complete reboot, or is it something you think can be addressed through local funding via ICBs, for example?
The actual sort of detail of the contract terms and conditions and so on is very much the role of the BMA. It is not our role at all. But I think that we're very closely aligned with GPC on this. I think that Cahill is now a little bit old, been around for well over 20 years. It does need looking at again. Times change, things change. Certainly, I have worked in very deprived areas since 1991. So, first in central Manchester, then in central Cardiff, now up in the Welsh Valleys. And I have seen many younger, very altruistic GPs who want to come and work in these areas because it is hard work. People have more illnesses, they lead chaotic lives. It's much more difficult sometimes, but transient populations as well. It's very much more difficult general practice. And these younger doctors want to come and work in these areas, and they don't stay because we can't earn enough to enable them to stay, and they move on somewhere else. And it's really dispiriting to see that happen. So we do have to have a change in some way. The problem is that if you've got a finite budget, what worries GPs is that if you give to one lot, you take away from another. So we have got to find a way to solve that wicked problem.
So Wes Streeting and the Labour government, they say they want to increase the share of funding going into general practice. So I'm assuming you would want to see this happen on a rising tide of funding going into general practice. So you would want to see a greater share of that funding going into deprived areas. Is that right?
Well, I think, that formula, even if it remains in some shape or form, needs to be tweaked so that there's more weighting that goes into deprivation.
Yeah.
And yes, we're also, just like GPC, asking for a greater share of the NHS budget to go out into community services and particularly into general practice. And Wes Streeting has particularly said general practice is the target of all of this. And of course, if the new government is expecting us to do more in terms of prevention and more services moving out of acute hospital into community, funding has got to go with it. Previous governments have been talking about this for decades. And what's happened is that some services have come out. We look after a lot more chronic illness than we used to, maintaining people with chronic illnesses, but the funding hasn't followed the patient, and that really must happen. If that happens and we have the resources and we have the GPs, we definitely have the brain power and the innovation and the desire to reform and do things better and differently to the way that we've done them before.
So talking of the new government, you've already met with Wes Streeting. What sort of issues were you raising with him in those discussions, and what will the college's focus be in terms of its conversations with the government over the coming year?
The reason for the meeting, ostensibly, was to talk about this new pot of money that he's managed to wrest out of the Treasury to employ newly qualified, otherwise unemployed GPs across England. And we wanted to establish that these roles would be substantive, that they won't just stop in March of next year. And we also wanted to give him some thoughts about what these roles should look like, that there ought to be protected time for professional development so that people can start developing extended roles in general practice and consider portfolio careers if they wanted, learning how practices work so that at the end of their salaried time, they may wish to become partners, and certainly one would hope would wish to stay in those practices where they're going to be employed. So that was the ostensible reason for going. But actually, of course, we were greeted very cordially, and he was really interested to let us go through the manifesto asks that we'd already produced a year ago when we had a very different reception from him. But this time he was definitely listening. So we talked about increasing the share of the NHS budget. We talked about deprivation and, ways in which we could work with government to look at how practices could be given a better share of income so that they could thrive in deprived areas. We talked about retention and the importance of retention schemes. This is another one of our worries, is that the long-term workforce plan, which was published for England last summer, implied that it was really focusing on general practice and was increasing the number of GP trainees by 50%. But when you actually looked into the detail of that plan and started looking at the tables at the back in detail, we could see that they were only modelling it on an expectation that there'd be a retention of about 700 GPs by the mid-2030s, which seemed awful. It seemed paltry to us. And then when the National Audit Office came along and produced its report on the long-term workforce plan, we realised that the modelling predicted a percent increase in general practice and a 49% increase in hospital consultants. And again, when you look at the original long-term workforce plan, where, beforehand, they wouldn't tell us what was in it, but they kept saying to me, Kamila, don't worry, general practice is getting a special mention. So, all those promises of special mentions and then a 4% increase compared to a 49% increase. And we've gone back to NHS England. And again, we discussed it with Wes and also with Stephen Kinnock to say how very concerned we were that they may be trying to pile in new GPs at one end, but they sure as hell weren't plugging retention properly and giving enough attention, focus to retention. We're losing people who are really experienced doctors and who are wonderful GPs, but who are becoming totally burnt out by the workload.
Well, there's a lot of issues there. All of those issues are things I want to talk to you about, actually. So maybe let's start with retention first. We spoke last year on the podcast about retention, and even then you felt there wasn't enough of a focus on that. In the past year, we've also seen the end of the fellowship programme for newly qualified GPs and the workforce plan problems, which you've just talked about. Do you get the impression that this new government is going to take retention more seriously?
I think it needs to. I don't know yet how seriously it will take it. It's definitely listening. I think NHS England are yet to be convinced that there's enough evidence that these retention schemes work. We've been plying them with evidence from all over the country that shows that GPs, particularly for the new to practice fellowships, 80% of them are more likely to stay in the practices where they've been placed. They develop extended roles. They learn about the joy of general practice and delivering continuity of care. To me, it's a win-win situation. And in fact, at the beginning of this year, I was really hopeful that we could persuade NHS England to magnify the New to Practice Fellowship Scheme, and so was just horrified to discover in January that they were planning to close it down by the end of March. I think that's just such a retrograde step. I've said it to them many times. They keep saying to me, we don't have the evidence. I keep saying to them, yes, you do. I've given it to you. And we've been also talking to DHSC about this because they haven't been in lockstep with NHSE on this. Wes, one of the things he's saying to them is that you need to work together much more closely. We're starting to see that. I'm not yet, maybe it's early days, seeing a change in views on how retention should be managed. So what seems to have happened is that the retention monies are now being divided amongst the ICBs, and each ICB on its own sort of local patch is working on retention. However, that money is not ring-fenced. There are so many claims on that money. I don't feel that it's getting the focus that it should be getting. And it's crazy to be spending lots of money on training good people and then allowing them to just trickle away. It's just crazy. So we've got a lot of work to do there, and I'm going to be banging that drum for a long time, I suspect, until somebody makes a change.
So retention is also a problem for GPs later on in their careers. We see more GPs retiring early or leaving early because of issues like burnout, workload. What does the college want to see happen about retention more broadly, not just on those fellowship programmes?
So ideally, what we'd like to see is an overall national overarching scheme on retention, a much bigger public push to the profession on the importance that NHSE, DHSC place on retention. If these local schemes are working, that money needs to be ring-fenced, and we need to keep tabs on what's happening because we don't really have enough data to know exactly what people are doing. As a college, we conduct our own surveys, and so we know from a recent survey of our GPSD3s that the vast majority of them do intend to stay in the UK and work in the UK, but almost half of them are having difficulty finding jobs. And that is pretty awful, really, when you've spent all these years in training and you're looking forward to getting stuck in as a GP and put those exams behind you. So I think it's something that we really just need to keep pushing on. I'd like to see an overarching national program that really publicizes the importance of retention with local funding that's ring-fenced and is being effectively used.
Also, you mentioned the workforce plan when you said you spoke to Wes Streeting and the real problems with the number of GPs predicted in that plan. And I know that when the new government first came in, you ran a call for college members to get them to write to the government to set out concerns about this. How many GPs do you think we should be aiming for in the NHS in England?
That's the difficult question, isn't it? How many? As you know, I think initially it was 5,000 more, and then it was 6,000 more. And you sort of, when you ask how do they decide on those numbers, it seems that they just sort of put a finger in the air and guessed. It all depends, really. And I know that NHS England is running some pilots across England. And one of the things they're looking at is, what is the capacity? What is the demand? How much more do we need in order to meet the demand? Everybody's accepting capacity is not equal to the demand. It depends on how you look at it. If you want to do sort of back of an envelope type calculation, which I have done, when I first qualified as a GP in 1988, we had approximately 1,700 to 1,800 patients per full-time equivalent GP. Obviously, the population is aging, there's more chronic disease, so you could argue that perhaps there should be fewer patients per full-time GP. But, just going on how things were back in 1988, we're now 2,300 patients per full-time equivalent GP, considerably more, together with all the additional work that I've just mentioned. So in order to get back to where we were, leave alone anything better than that, I've worked out that in England, we'd need at least 6,000 more GPs. Probably more than that. That's 6,000 full-time equivalents. And we know now that most GPs coming through will not be working the full 10 sessions a week clinically. They will be working, they'll do other things. Portfolio careers are far more popular than they ever were before. And having had one for most of my working life, it has certainly kept me fresh and happy to see patients when I'm in practice. but also happy to go away and do something else in order to refresh my brain. And initially, for me, it was in diabetes and then in rheumatology and then in medical education. It doesn't have to be the same thing all the way through your career. And of course, now in medical politics for me. But, there's so many other extended roles that GPs can do. We're a really versatile lot. And one of the things that we're doing as a college is we are promoting and supporting accreditation for extended roles. So do please get in touch with me and I will pass whoever does on to the relevant organisation within the college if there is an interest in extended roles.
I mean, it's an important point, that, isn't it, about portfolio careers? Because obviously the media is often quick to pick up on the fact that GPs aren't working full time, but they're often doing very, very long hours in surgery and then having other jobs on top of that.
Yeah, 6 sessions a week in general practice. The sessions, they're not 4 hours long. They're often well over 6. And even doing 3 days a week in general practice, you're easily doing 40 hours a week, which is everybody else's full time. And you're working, you're starting at 7 in the morning and you're finishing at 7:30 at night or 8 o'clock. You go home, you eat, and then you get onto your computer again to do your path results or your letters or your referrals, or, it is a huge workload.
But all those other roles as well that GPs have in their second jobs or whatever as part of their portfolio career, those are obviously all very, very important things that kind of help improve the NHS, help improve patient care on a wider scale, aren't they often?
Yes, they absolutely do. There's all sorts of things that people are doing. I'm constantly amazed and delighted to discover what people are doing.
You mentioned earlier about changes to the ARRS to include GPs. What's your view on this? Do you think it's going to help with the jobs problem that newer GPs are facing?
I think it's a sticking plaster. In the short term, it will mean that otherwise unemployed GPs will find employment. And from that point of view, I'm really pleased. I think coming through the ARRS scheme has got certain difficulties and dangers, because if it's coming through PCNs, it could be, for example, a PCN that actually wants that doctor to work across 4 or 5 different practices, which I don't think would be good for a new GP. I really want them to be settled in one practice, get their feet under the table, and really learn what it is to be a GP and really get to know their patients. I don't want them to be internal locums within a PCN. I've been assured that that won't be the case, but we will be issuing some guidance as to how we would like these roles to develop within the PCNs. But actually, looking ahead, what further funding comes through to practices needs to come through core funding. Again, that's very much the role of GPC and BMA. Katie Bramall-Stainer and I meet and discuss this frequently, and we're very much the same mind on this. For now, we had been asking government to open up the R scheme to GPs and practice nurses. I wasn't expecting that he'd be able to find money for it as well, ring-fenced money. And that's really been icing on the cake, because otherwise what would have happened is, because there wasn't much left in the R's budget, is that only some GPs would find a job, whereas now they're talking about 1,400 jobs for GPs this October, which is amazing. And also some practices would have been making other healthcare workers redundant in order to take on GPs instead. And of course, we don't want to see that happening either. So this is great that he's done it. I think it's been a huge effort to get that money out of the Treasury. It shows what he's capable of, really, and that he's listening. So going forwards, I'm hoping that we'll be able to talk very constructively about how we can turn around things in general practice.
You said you'd spoken to him about whether the funding would end in March or whether it would go on, or whether these jobs would be substantive posts, because obviously the fear is that they're just not attractive jobs, are they? If these are fixed term contracts, that's not necessarily the kind of jobs that people want. So do you get a sense that it's not going to be like that when this actually starts?
Apparently not.
Right.
I was reassured of that when I met with Stephen Kinnock. It was absolutely made clear to me. Amanda Doyle was at that meeting as well, that these are substantive posts, and that is the word that they've been using. So my assumption is that that means they will go on beyond March of next year, and that people don't need to fear. And we've got enough to worry about, haven't we?
Even with this, though, are you worried that recently qualified GPs are going to struggle to find jobs?
Yes, we don't really know exactly how many GPs will be looking for jobs, but 1,400, of course, is better than 0. So that's good. Some people may have to move to find a job, but then, we all did in our time. I did. It's not always what you want. But having said that, once you get stuck in and you've moved, as a substantive job, you won't be having to move again, because the job's gone. The job will remain.
Do you feel generally positive about changes that could come under the new Labour government?
So when I was writing this manifesto, which was in the summer of last year, I'd never written one before. So I had a look to see what my predecessors had done in their manifestos. And over the last few manifestos, approximately 5 to 7 asks per manifesto, of which I then realized about 2 get realized. And they don't happen straight away. And it sort of comes sometimes in ways you're not expecting. And so when I wrote our manifesto, which has 7 asks, I thought, well, maybe 2. But actually, it's looking at least 4 at the moment. And yes, I'm very hopeful that if we carry on in the way that we've begun, in a collaborative way, quite clearly the Department of Health want our help. Quite clearly they want our ideas. Quite clearly they want our input. We have to bring NHS England with us, and they are very used to working in a particular way. So that needs to change, I think. But I'm very, very hopeful that if things carry on in the way that they've started, we're going to see a difference. Some of the things that are being said are really very high level headline stuff, publicity catching stuff like, we will bring back the family doctor. Okay. But I'm not sure that I want to bring back Dr. Finlay. I was Dr. Finlay back in 1988. I worked all hours, on call all night, on call all weekend. It was really difficult. And especially now that the workload is so much higher, I think that will be terrible for general practice. So what we want is a 21st century family doctor, not a 20th century family doctor. And so we have to be careful what we're asking for. But at the same time, this is an opportunity to really liven, re-establish general practice, because without it, the NHS just can't manage.
Which 4 of those manifesto pledges do you think that potential progress will be made on?
Well, I think the increasing the share of NHS funding for general practice, that's definitely one that's being promised. Providing more support to patients in deprived communities, that's also being talked about. Growing the GP workforce, that's also being talked about. Although the retention, I think, there's still a bit of headbanging needed there. Modern fit-for-purpose general practice buildings, I think that's definitely been accepted, that practice premises need really looking at. It caused a major upset a year ago when we launched the manifesto because we were asking for 2 billion, if you remember, in infrastructure costs. Again, slightly back of an envelope calculation, but I think it would be at least that. And at that point, I was being told we don't have a blank checkbook. So we'll see, but that's about 4 already, isn't it? Bureaucracy, definitely. I think there are going to be changes to QoF. We're very keen on a national alert system, like an OPEL system that secondary care has. It's not being promised by the government, but we've actually found places in England that are working on it, and we're working with them. So maybe through a back door, we'll get that one. So that's 6 of the 7. And the 7th one is about guaranteeing permanent residence to international medical graduates who qualify when they CCT as GPs. At the moment, we're still having to work hard on that one. We're very, very keen that should happen because we know that over 50% of our trainees are international medical graduates, and we're delighted to have them here, and we need to make them welcome and feel that they're wanted because they are, and needed because they are. And if Australia can do it, why can't we?
That's quite interesting, isn't it? Because that last one, that 7th one, which you said is perhaps not happening, that's possibly the easiest one out of all of those things on that list to actually do something about.
That's actually what I said to Wes. If you want, it won't cost you any money. All it means is that you need to twist at the arm of the Home Secretary. But I say all, but it's going to be much more difficult than that. Yeah, it won't cost you, and it would be an amazing thing to do. I think the important thing for me is that I think there is light. I'm seeing hope and I'm seeing light. I think the new government definitely is talking the talk, and we want to help it walk the walk. It's not just about holding feet to the fire, although of course there'll be a bit of that. It's also how can we help them so that we work together and we do it together. The new government has approached us with such a positive spirit of collaboration that it is really difficult not to reciprocate, and that's what we want essentially for our patients and for general practice.
Well, that's good. That's really positive, isn't it? And that does feel like a real change from how things have been for quite a few years.
It really does, because you know how it felt when I first started was it pushing on the door, pushing on the door, pushing on the door, you know, and you're having to bargain. I remember when we got the 4-month extension to tier 2 visas for international medical graduates, I'd had a conversation with Rishi Sunak's special advisor about this. And he'd said, well, how about 3 months? And I said, well, how about 6 months? And we ended up with 4. You know, that kind of bargain, you know, that's just silly.
You mentioned the government talking about bringing back the family doctor, and there has been discussions about the government being very keen to incentivise continuity of care. I mean, the college has always backed the importance of continuity as the cornerstone of general practice. But do you think incentives are the right way to make this happen? And if not, you know, how can we make continuity a reality for patients?
So I think it's worrying that the word incentives are being used. Depends on how you use it. You know, if you set up a QOF system, I think that that is going to end up as another rod to beat GPs with. I think that continuity of care is vitally important. We know how good it is for patients. We also know how good it is for the caregivers, for the doctors. Get much more job satisfaction from caring for people on a regular basis. So it is absolutely vital. We're more into quality improvement programs so that people can demonstrate how they are improving continuity of care for patients, especially right now when we're so short of GPs. And there's this real push to improve access at the expense of continuity, like a balancing act. The more attention you give to access, the less you can give to continuity. So we've got to get this balance much better. We need more GPs to be able to do it. We need then practices to be able to show how they're doing it, you know, whether they're doing it by personal continuity, that transactional conversation with patients, or whether they're doing it by creating mini teams within practices. As a GP, you'd team up with pharmacist and a practice nurse, and the patient will see one of you 3 rather than just you. But we still need to be looking at the evidence for this. Most of the evidence we've got is on the one-to-one doctor-patient relationship. So there's still a lot of work to be done on that, on how we do it and how we do it well.
We're speaking ahead of the annual conference, and this interview will be coming out just as the conference begins. Can you give us any insights into the issues you'll be talking about in your conference speech and the things you want to raise with RCGP members this year?
Okay, so no spoilers, because everybody must come or listen. So I'm not going to give too much away. Definitely we'll be covering retention, because I think it's still something that we need to headbang about, what we want to see from the new government. And I'll also be covering health inequalities.
Thank you so much for your time, Kamila. Thank you for coming on the podcast. I really appreciate it.
Pleasure, Emma. Thanks for having me.
Well, that's it for this episode. Thank you so much to Kamila for taking the time to talk with me. As I said, this is the first of 3 special episodes we're doing from the RCGP annual conference. Tomorrow I'll be looking at what Kamila had to say in her speech to the conference and reviewing some of the other things going on here in Liverpool. I'm also speaking to Dr. Joy Shacklock, the RCGP's safeguarding lead, about the college's new safeguarding standards which are being launched tomorrow. So please do join me then.